Imagine being told that a vital organ inside you could fail, but the treatment that you receive to fix your organ was never designed with you in mind. Take a moment. Look at the person to your right. Look at their shoes. Look at the person to your left. Look at their shoes. They're all different, right? By and large, men's and women's shoes are different. Some fit really well, some not so well. Some are built for comfort, others not so much. Sure, you'd want a medical device implanted in you, a life-saving medical device that is designed for you and not designed for the person sitting beside you. Contemporary medicine is designed on the assumption that we are all the same, but one size does not fit all. However, medicine is changing. Artificial intelligence, or AI, is bringing us ever closer to personalised medicine every single day. Let's talk about aortic disease. Who here knows where your aorta is or what its function is? The aorta is a vital organ. It is your largest artery. It is that central transport system that brings oxygen-rich blood from your heart right down through your torso to supply your limbs, your organs, your tissues. If it fails and the wall dilates, becomes thin and ruptures, you will die. This is called aortic aneurysm, and it affects about 8% of the population. So at the moment, 15 to 20 of us in this theatre have an aortic aneurysm or will have one at some point in our life. If we have one and it ruptures outside a hospital, we have 80 to 90% chance of death. However, if we treat it before it ruptures, we have a 99% chance of survival. The only problem is the aortic aneurysm is usually asymptomatic. So oftentimes your first symptom is a fatal rupture. Cardiovascular diseases are the leading causes of mortality globally. That's for both men and women. And aortic disease is a third leading cause of cardiovascular death. But aortic aneurysms or aortic diseases are the only cardiovascular disease that has seen no improvement in survival in the last 4 decades. Many of the guidelines that we adhere to in medicine are based on the idea that one size fits all. This is because modern medicine is by and large designed by and for middle-aged white men. But like our shoe size, we are not all the same. We need more data on women, on minority groups, on patients with genetic disorders, or patients with other serious medical conditions, so that we can develop more personalised and more targeted therapies. Why am I so worried about the aorta? Well, I'm a vascular surgeon. I treat people with aortic disease, but I'm also a scientist. So I spend 50% of my time working in the hospital treating patients with vascular diseases like aortic disease. And I spend the other half of my time in the lab, in the university, trying to figure out why we are getting aortic disease and what can I do to fix it and what therapies can I develop. Well, today I decide who gets life-saving surgery based on one single dimension: the diameter or the width of your aorta at its widest point. As if I am blowing up a balloon, and every time you blow up a balloon, it bursts at the exact same diameter. This is not the case. My guidelines tell me that I should operate on an aneurysm when it is 5.5 centimetres. But I've seen aortas rupture when they're only 4 centimetres, or the size of a mandarin. And equally, I have seen aortas not rupture when they're 20 centimetres, or the size of a watermelon. This is because biology is not one-dimensional. History matters, behaviour matters, and risk does not look the same in everybody. When, as a surgeon, I want to look at your aorta or any of your vital organs, I use a CT scan, an MRI scan, or a PET scan. And this gives me an idea of what is happening with your organ at this moment in time. But it will not tell me what is happening in your organ in 2 or 5 years' time. Wouldn't it be great if we had a computerized replica or a digital twin that could tell me what's going to happen in your body and your future? Imagine if we could put your geometry, your biomechanics, your blood flow parameters into this digital twin and make it so specific to you. That transforms imaging from a snapshot in time into a living, evolving organ. Currently, if I want to run a computerized model of your aorta, I need hundreds of hours in a supercomputer. But AI is working to make this faster. We're at the beginning of an evolution, but it's going to take time. We need steps so that we make sure that the AI we use is safe, reproducible, and trustworthy. But we are at a critical point. We can now answer questions like, well, why is disease progression different in women? Or even more different in women with high blood pressure? And how do heart disease and smoking contribute to this over decades? When a digital twin integrates your DNA, your genes, the cellular components of your aortic wall, the strengths of your aorta, and how blood flows through your aorta, and then integrates all of this with your clinical history, then it becomes something completely different. It becomes an organ in its own right, a computerized organ. A digital twin can virtually age. It can weaken. It can react to disease, and it can respond to treatment. When patients contribute their genetics, their tissue, their clinical imaging, and their lifestyle, these things make us an accurate digital twin. And all of these factors leave biological and mechanical fingerprints on your aorta. Digital twins model these fingerprints explicitly for you, rather than smoothing them out into population generals. So let me be specific. Let's consider gender. Women's aortas rupture at smaller diameters than men's. A digital twin can capture this so that we can understand the mechanics and the differences between men and women. Smoking changes your genetic expression and it weakens your tissues. Digital twins can capture this so that we can understand why smokers have faster disease progression and why they rupture at smaller diameters. The most powerful application of digital twins is virtual treatments. We can virtually implant many devices in patients. We can simulate these implantations in different patients with different risk profiles and different health conditions. And we can even depict how these devices will get complications in the long term, or how disease will naturally progress in the long term. This is particularly important for patients who are underrepresented in current clinical trials, like patients with genetic issues or women. Now imagine scaling this up. With a tool called generative AI, we can build virtual populations from all the information that we have gathered together in making these patient-specific digital twins. Virtual populations allow us to perform virtual trials. So now we can implant devices in thousands of virtual patients. This doesn't get rid of human trials, but it just makes them more inclusive, more efficient, and more equitable. Now imagine a future clinic where a patient, your child, or your grandchildren, no longer ask, what happens to other people with this disease? Instead, they ask, does my digital organ tell us a future? What does my digital organ tell us? A future where decisions are based on their own biology, their own lived experience, and a digital twin that truly represents them. Using a personalized medicine approach, digital twins will allow us to decide who needs intervention, when do we need to intervene, and how do we need to intervene. Using this approach, and by supporting collaboration across disciplines, from cell biology and computer modeling to generative AI, we are working together with patients to build a tool that will redefine who medicine is built for. Thank you.